questions, just stop and ask, and I'll be happy just to. I'm a pretty simple guy, and so I'm not super sophisticated. So I'll just put it in the simplest terms because that's kind of how I think about things.
Okay, thanks, Dr. Commander. So, so here's just an outline of the presentation today. So we'll be going over just an overview of gastric varices and the management of gastric varices. Then we'll be talking about a specific paper, the endoscopic cyanoacrylate injection versus BRTO for prevention of gastric variceal bleeding, an RCT. And then finally, we'll do a Q&A with Dr. Commander. And so we'll be using Slido for answering questions. So if everybody can just scan the QR code, or you can go to the website. And once you do that, you'll be able to answer the questions. There's a Q&A segment that throughout the presentation, you can also just go on the chat and maybe Dr. Commander, you can answer the questions on the chat. But if you can also write it on the Q&A, and we'll have a dedicated time in the end to do a Q&A with Dr. Commander.
Sure. Do I need to go to the Slido thingy too?
No,
I've never done this before. You guys are so hip. I'm just.
Yeah, you could just answer the questions unless you want to like. Ask
okay.
Yeah.
Yeah, got it. All right, cool. Thank you.
Yeah. Okay, so just to make sure that we have everything up and running, if everybody can go on Slido and just answer the question, where are you joining us from?
And while everybody's doing this, I'll just tell you thanks for doing it later in the evening. Thanks. I'm sorry. It's my fault. Thank you for doing that. I've got 3 kids and 1 is a newborn, and my wife's also a doc. And so anyway, thanks for accommodating me this evening.
Absolutely. Thank you so much for making time for us, Dr. Commander.
Yes, thank you, Dr. Commander. And great. Looks like we have a whole from everywhere, which is awesome. Okay, and so this is just a picture of the paper that we're going to be talking about, but first we're going to have an introduction to Gloria with Gloria. So go ahead, Gloria, take it away.
Okay, awesome. Thank you. So I'm going to be talking about the clinical portion of gastric varices and the bleeding, the clinical presentation, and the treatment. So what is a gastric varices? It's when there's a dilated portosystemic collateral vein, and that's going to occur when there's a blockage or occlusion to blood flow to the liver. So an example is splenic vein thrombosis. So the prevalence in the United States is reported to be about 15 to 20%. The incidence of bleeding is about 10 to 30% in patients who have portal hypertension. So this is pretty serious when there's bleeding going on because it can be life-threatening, it can cause mortality. So we have to be screening continuously with an EGD. So the most common cause of a GV or gastric varices is going to be cirrhosis secondary to portal hypertension. Now, cirrhosis causes decreased clotting factor synthesis, so this can actually exacerbate bleeding. Another cause is splenic vein thrombosis secondary to chronic pancreatitis, pancreatic cancer, and hepatitis C. And this can occur without cirrhosis being there. With the pathophysiology, we have some decreased hepatic vasculature tone, an elevated HVPG or hepatic venous pressure gradient, and this can occur from that blockage or occlusion to that portal blood flow. So we're looking at about greater than 10 millimeters of mercury, and then we're going to have that collateral shunt that's being created. So with gastric bleeding, the HVPG would be a little greater than 20. So we'll do a quick overview of anatomy. There's 2 pictures here. We'll focus on the right one. We're looking at the portal vein, the left gastric vein, and then we have here the splenic vein, and then the IVC and the SMV. So the most common shunt that's formed is the gastrorenal shunt right here. And then the lesser common one is the gastrocable shunt right there. So we'll talk about this more later. Some of the common symptoms of GV is hematemesis, melena, hematochezia, and then cirrhosis, since it's the most common cause of GV secondary to portal hypertension. We want to be looking at for spider angioma, telangiectasias, caput medusae, palmar erythema, gynecomastia, and hepatosplenomegaly. So a Slido question, but what is the most common etiology of gastric varices? And feel free to do that with that QR code. Okay, awesome. So everyone got it. It's cirrhosis secondary to portal hypertension. So with the initial workup for labs, we want to check hemoglobin, hematocrit, and platelet counts. And this is because for GV, there's some low red blood cell counts that can occur in thrombocytopenia. We want to check PT, INR, and fibrinogen, because again, we're looking at cirrhosis being the most common cause and liver disease overall. So the PT and INR can be prolonged, and there can be some decreased fibrinogen. EGD is going to be that initial workup. We want to look at risk stratification. And we can also order and look at a CT, MRI, or ultrasound to diagnose a sequelae of the portal hypertension. So we're looking at the EGD here. And with the arrows, we see these squiggly dilations. So this is going to be that gastric varices. And there's a bunch here, and some here. And again, we're still looking at the EGD, and this is showing all the bleeding going around. Now this is a CT with contrast. So what do you guys all see here? Feel free to unmute or type in the chat, but look within the red circles here.
Looks like tortuous splenic veins.
Awesome, awesome. Yep, and thank you, Patel and Dr. Commander. So yeah, exactly, the cluster of grapes. So yeah, when we're looking here, we have this lobulated mass, the opacities, and they're showing the dilated tubular structures in the gastric fundus. So we're seeing some enhancement after contrast. And like Dr. Commander was mentioning, we have the cluster of grapes image here that's showing the bleed and the GV.
I don't know if that's a term everybody uses. I may have coined that, or I've heard it somewhere. I don't know. So don't go spouting that off to your fancy pants attendings at your institutions. I'm like, what dum-dum taught you that? I mean, that's what I call it. So it looks like to me. Yeah, right.
Yeah, it does look good. Thank you. And then we want to go ahead and classify the GVs. So there's something called a Saren's classification. There are 4 anatomical types. So GOV2 and IGV1 are considered true gastrovarices or true GVs. And that's important for meticulous pre-treatment and then further imaging for shunts. And then GOV1 is treated as an esophageal varices. So that's with more like an endoscopic band ligation. And then with those shunts, we want to further classify them. So we can use the Kiosu and Sod Caldwell classifications. And so this is going to be a triphasic CT classification. And you identify this abnormal shunt, and then you go to the next step management from there. So Kiosu type B, that's one of the most common ones. That's a gastrorenal shunt. And then the Sod Caldwell type 2B, that's another most common one. And that is also a gastrorenal shunt. With general management, we want to give them IV fluids to stabilize hemodynamics, potentially give them a blood transfusion if needed, and then octreotide, and that can help with vasoconstriction, and then restricting that portal flow. Antibiotics can be helpful, and it lowers mortality. Non-selective beta blockers are really helpful because they result in unopposed alpha vasoconstriction, and this can also decrease that portal venous flow. And then we have the endoscopic band ligation. This is just a big overview. And so we're focusing on this right image here. It's kind of breaking it all down. But essentially, we're looking at whether or not there is an efferent shunt or not. If there's no efferent shunt, just kind of go ahead and do an ECI. That's an endoscopic cyanoacrylate glue injection. If there is a shunt, we break it down into portal vein being patent or occluded. If occluded and the patient has hepatic encephalopathy, you can do the ECI and a BRTO, which we'll go over pretty soon. If there's no HE, a BRTO. If the portal vein is patent and the patient does not have ascites or HE or large esophageal varices, do a BRTO or PARTO. But if they do have these qualities, especially a hepatic encephalopathy, do that glue injection with the BRTO and TIPS, and if no HE, TIPS. So going over these interventional treatments, we have the retrograde transvenous obliteration, or the transjugular intrahepatic portosystemic shunt, or TIPS for short. So the most common RTO versions are BRTO, which is a balloon, PARTO, plug, and CARTO, which is a coil. So these guys essentially occlude these dilated vessels in a GV, and then they can help reduce that rupture risk. This is a catheter-guided process and use fluoroscopy. And with this, you can visualize and then occlude that shunt with the balloon or plug or coil, and then you can inject an agent like a sclerosant. And we'll talk more about this with the article later on, but it has been found to require less post-procedural ICU care, and that can be potentially more beneficial to the patient care overall. So we're looking at the gastric varices here, and the coils, and then the sclerosant injection that comes afterwards. And a quick overview of TIPS. So we can use a stent, and this can route the portal flow directly to that hepatic vein here, and it can partially bypass that liver. So this offloads the portal venous system, and it reduces that pressure, so it's pretty helpful. And then we have the cyanoacrylate glue, which is essentially a dermabond or like a topical skin glue. It can rapidly polymerize into plastic when it comes upon contact with blood or water, and it's helpful for hemostasis. In terms of post-op care, so with those RTOs, you can order a blood gas, chest x-ray, or blood tests. You do want to go ahead and repeat an upper endoscopy or EGD with CT or MRI with contrast in about a month or so, just to confirm if those gastric varices are occluded. And then you're looking for new signs of portal like hypertension, essentially if there's any esophageal varices. With TIPS, you're monitoring the fluid status and then monitoring for asterixis. In terms of complications, with the RTO, there is a risk for rupturing for existing esophageal varices. There can be some GV rebleeding. For TIPS, the hepatic encephalopathy is concerning and potential liver failure. With the glue, there is some GV rebleeding and then potential liver disease decompensation. But overall, it's kind of a good loop and reminder, IR and RADS and everyone else as a team working towards patient care. And we will move on to Deshaun's portion.
All right, thanks, Gloria. So we'll be talking about this trial that was published in 2021, looking at endoscopic cyanoacrylate injection versus BRTO in terms of preventing gastric variceal bleeding after primary hemostasis. So the background, so at the time of this study, there was some controversy that existed whether endoscopic or endovascular approach was superior for the prophylactic management of against rebleeding. Since there wasn't any consensus in the evidence, the management was usually based on expert opinion or local state guidelines. And so this is the first study that was level 1 evidence looking at evaluating this question. Previously, the literature had shown that gastric variceal rebleeding rates following cyanoacrylate or glue was around 15% to 38%, whereas following BRTO was around 0% to 9%. Thus, Luo et al., the authors of this paper, they hypothesized that the rebleeding rates of 30% for glue and around 3% for BRTO would probably be seen. So just to be clear, so the purpose of this study exactly is to compare the efficacy and the safety of endoscopic cyanoacrylate injection versus balloon-occluded retrograde transvenous obliteration, BRTO or BRTO, to prevent rebleeding in patients with cirrhosis and gastric varices after primary hemostasis. So here is the inclusion and the exclusion criteria. So for the inclusion criteria, the patients had to have been admitted to their institution, Luo et al.'s, which is the West China Hospital, between June 2015 and February 2018, ages 18 to 75. The patients had to have been admitted for fundal gastric variceal bleeding, or they had to have been transferred from a hospital from a previous acute gastric variceal bleed within 4 weeks of the primary hemostasis. And the bleeding was considered gastric variceal in origin if there was active spurting or oozing of the blood seen in endoscopy, if there was blood clots, white nipple sign, or presence of erosive spots on the gastric varices, presence of a red color sign on the gastric varices. And those two things I'll explain what they are on the next slide. And the cirrhosis had to be the diagnosis that caused this gastric variceal bleed. And the way they confirmed these diagnoses of cirrhosis was with a liver biopsy, medical history, physical exam, and biochemical or radiological findings. And for the exclusion criteria, it was if there had any previous secondary prophylactic treatments of the gastric varices, obviously that would confound the study, so that was excluded. Absence of a portosystemic shunt was excluded. You can't do BRTO without that. Non-cirrhotic portal hypertension, portal cavernoma, advanced malignancy, end-stage renal disease with renal replacement therapy, cardiorespiratory failure, pregnancy, and if the patients just flat out refuse to participate. So here's an example, just two pictures of what the white nipple sign and the red signs are. So on the left, you can see the white nipple sign, which is that white, the white lesion there. And that's caused by a newly formed fibrant clot. And on the right, you can see the red signs. And there's also a red whale sign, a longitudinal streak that you can usually see on the gastric varices. And if you see either of these signs, it goes to show that there was a recent hemorrhage, either that's clotting or there was a recent hemorrhage. And so this is what Luo et al. Used to, in the absence of any other bleeding, if you had seen one of these signs on the gastric varices, you know, you have a pretty good shot that that's where the bleeding is coming from. And so here is just a graph in the paper of how they allocated the different groups. So patients were, there was 147 patients who were eligible for the study, and around 22 of them were excluded based on the criteria that was outlined in the previous slide. And then a total of 64 were randomized into two groups, a cyanoacrylate injection group and a BRTO group. And then only one person refused to allocate for the allocated intervention and the cyanoacrylate group, and that person was given propranolol, but the rest of them were able to go ahead and do that treatment. So for the cyanoacrylate group, the way they went about the treatment was within 3 days of randomization for both groups, the treatment was started. For the cyanoacrylate group, they would, after flushing their needles with around 50% glucose, they would inject undiluted N-butyl-2 cyanoacrylate into the gastric varices, followed by another 50% glucose flush to make sure the glue was all removed from the catheter. Each injection was up to 0.5 milliliters of glue, but no more than 2 milliliters of glue was used into one or injected into one varix. They would try to obliterate the gastric varices in one session, but by injecting them into the multiple sites and confirming the probe using a blunt probe. But if not, they continued the injections in 4-week intervals until the gastric varices were obliterated. For the BRTO group, under local anesthesia of they would use an occlusive balloon catheter inserted through either the femoral vein or the internal jugular vein into the spontaneous portosystemic shunt. And then the size of the balloon catheter was determined by the shunt's diameter. Retrograde venography was performed, and collateral veins, usually the inferior phrenic or the paravertebral veins, that usually prevent visualization of the gastric varices, were embolized using coils or by injecting 10% polydocanol, which is a sclerosant. And once the gastric varices were visualized, they would use a combination of room temp air, contrast media, and polydocanol in a 2:1:1 ratio and it was injected stepwise until the feeding veins were visualized. And so, if you can go next, Gloria. So here are the two different groups and what I had just talked about. And for the BRTO group, another thing to note was that the balloon catheter was left overnight before deflation. And I know Dr. Commander was talking about how BRTO is actually starting to fall a little out of favor because of how long the balloon has to be left in after these treatments. So you can talk about that later after during the Q&A session. So go ahead and go next, Gloria. So here are some additional characteristics of the group. Hepatitis B infection was the most common cirrhosis etiology. Around 51% of them had detectable HBV levels on admission, and they were prescribed oral antivirals to bring down the viral load. 4 of the patients in the cyanoacrylate group and 6 patients in the BRTO group had detectable levels of the HBV DNA. However, this was not a significant difference. So they went ahead and kept going with the treatment. In terms of the types of gastric varices the patients had, 22 patients had, which is around 69% in the GLUE group, and 20% in the BRTO group had GOV2 gastric varices, and the remaining ones had IGV1 gastric varices. So all had true gastric varices. The mean follow-up duration was 27.1 plus or minus 12 months in the cyanoacrylate injection group, and 27.6 plus or minus 14.3 in the BRTO group. So no significant difference there. And so here is just a chart showing the different characteristics between the two groups. And it's just important to realize that the p-values for all of these are non-significant. So essentially, there's no difference between the two groups of 32. So the outcome and definition. So the primary outcome that they were looking for was gastric variceal bleeding and all-cause rebleeding. The rebleeding was defined as recurrent melena or hematemesis and was evaluated by endoscopy whenever possible. Major rebleeding was classified if the rebleeding required hospital admission, required a blood transfusion, had a greater than 3-gram drop in hemoglobin, or resulted in death within 6 weeks. All of the other bleeding was considered minor bleeding. So here's a little bit about the statistical methods that they employed for the study. So the differences were detected in an alpha of 0.05 with a beta of 0.2. The comparisons for normally distributed data, continuous data, was done using a student's t-test, and for the categorical data was a chi-square test or a Fisher's exact test. Rebleeding and mortality was estimated using a Kaplan-Meier method and compared with a log rank test. Primary analysis was conducted on an intention to treat basis, and abbreviated ITT on the graphs. And univariate and multivariate analysis were done with a Cox proportional hazard regression, and only statistically significant with a p of under 0.05 of univariate data would be included in a multivariate analysis. And all the tests were two-tailed. So here's another Slido question. Which treatment group did Liu et al. Hypothesize would have lower rates of gastric variceal rebleeding? Awesome, so everybody got that one, which is fantastic. All right, so moving on to the results. So during the follow-up period, 11 patients developed rebleeding from the cyanoacrylate group, and only 2 patients from the BRTO group had any rebleeding, with a p-value of 0.005. So very strong, statistically significant data here, showing a difference in rebleeding rates. The probability of gastric variceal and all-cause rebleeding was significantly higher in the cyanoacrylate group than in the BRTO group, with a p-value of 0.024. So basically, all-cause rebleeding and gastric variceal specific rebleeding were both significantly increased chance of happening with the cyanoacrylate injection group. Next. And so here is a graph of this. Here's a graph of the probability of remaining free from gastric variceal rebleeding. So this is a graph showing the 1 and 2 year cumulative probability of remaining free of gastric variceal rebleeding. And you can see it's significantly higher in the BRTO group with a p-value of 0.024. They also did a univariate analysis of the factors that are causing this. And they found that MELD score was associated with a higher gastric variceal rebleeding risk. And a MELD score is a model for end-stage liver disease score. It's scored from 60 to 40. The higher the score, the more severe liver disease is. And it's calculated by taking the values of creatinine, bilirubin, INR, and as of 2016, also sodium as well. And basically, it tells you how bad the liver disease or how severe your liver disease is. So they found with univariate analysis that the MELD score was actually prognostic of the gastric variceal rebleeding. This next graph is showing the same thing, but for all-cause rebleeding. And this is, it also shows that it's significantly higher in the BRTO group than in the cyanoacrylate injection group with a p of 0.004. So specifically, the probability of survival after 1 year is 96.3 in the BRTO group and 77% on the cyanoacrylate group. And then after 2 years, 92.6% on the BRTO group and 65.2% on the cyanoacrylate group. So across the board, pretty much, the BRTO group had a higher chance of remaining free from rebleeding. Next. And so here is a chart showing the multivariate and univariate analysis of the all-cause rebleeding. And they found that a BRTO and the MELD score, again, were prognostic of the all-cause rebleeding. For complications and mortality, interestingly, there was no significant difference in the complications or mortality between the two groups. As you can see in the graph here, there was the complications for the cyanoacrylate group was 16 and BRTO group was 17. And so there's not really a significant difference there. And most of the deaths were caused by liver failure or infection. And both groups had 4 deaths. And next. So here is another graph showing the probability of survival between the two groups. The main thing to look at here is that the p-value is non-significant and corroborating the results of the graph. And in 1 year, the BRTO, for specific numbers, the BRTO survival rate was 93.8%, the cyanoacrylate was 87.5%. And for 2 years, the BRTO group was 86.2% survival rate, and the cyanoacrylate group was 84% survival rate. So similar survival and complication rates for both. And here's just a graph showing the causes or prognostic factors that can affect mortality or increase the risk of mortality. They found that HBV related or HBV cause of cirrhosis was one of the factors that would increase the likelihood of mortality. The presence of ascites, and once again, the MELD score, having a higher score leading to a higher risk of mortality. So what do these results tell us? So the results clearly demonstrate that BRTO is more effective than endoscopic cyanoacrylate injection to prevent rebleeding from fundal gastric varices, while still having comparable complication and mortality rates. And Liu et al. Reason that the similarity for the mortality rates is most likely due to the prevention of gastric variceal rebleeds can be counterbalanced by worsening esophageal variceal rates. So the main complication seen from the BRTO group was worsening of esophageal varices. And so that might be a reason why the mortality rates are and the complication rates are similar. Along the same vein, the endoscopic management, although can have a higher rebleeding rate, still effectively controlled most of the rebleeding rates for mortality, with only one patient dying to torrential bleeding. And across the board, like I mentioned, for all causes of rebleeding, including gastric variceal rebleeding, the baseline liver function, aka the MELD score, is the most important determining factor for long-term outcomes. So limitations of this study. So I think it was Dr. V who mentioned it in the chat earlier, but beta blockers are a mainstay of usual treatment for patients with portal hypertension because it can lower the portosystemic gradient. And for this study, beta blockers were not given to either group, which is a major limitation for this study. And it can reduce the risk of all the major complications we've seen with worsening esophageal varices, ascites, and other portal hypertension related complications. Another potential limitation is, as Gloria mentioned before, preemptive tips can be indicated for some of the management of these patients and to prevent rebleeding and improve the survival rates with cirrhosis and high-risk variceal bleedings. So it's unclear how the preemptive tips procedure may have affected these treatment groups. So in summary, this study is the first level 1 evidence study of its kind that shows that BRTO is markedly more effective than endoscopic cyanoacrylate injection to prevent gastric variceal rebleeding and all-cause rebleeding, while still having similar rates of complications and mortalities. Worsening esophageal varices secondary to BRTO was actually in the literature before this study as well, and is generally seen as a major complication of this procedure. And Liu et al. Said they suggested better endoscopy follow-up strategies should be investigated in the future to prevent this major complication. And here are our references. And thank you so much for listening to our presentation. And Gloria, you can start off the Q&A.
Okay, awesome. Thank you, Deshaun. So we're gonna go to the Slido here. Feel free to put in your questions with the QR code, but for Dr. Commander, how are gastric varices treated at UNC? And are there any unique differences in treatment modalities compared to other places or experiences?
Sure. One thing, can you go back to your slide? Are you still on your slides? Can you go back? I want to kind of, can I share kind of just what I'm thinking off the top of my head about this and why I think the results, I think one could have predicted that the results of this study would have been this way. And I'll just tell you how again, I told you guys I'm a simpleton and just, I'm very simple in my thinking. And so this is how I think about these things. And once you do one of these cases, you will see what I mean. Go back to where the pictures were early on. Yeah, when you were showing like the shunts and so on. Yeah, there, go back forward one. Or actually, that's a pretty good one too. But so it's important to recognize in this, go forward one slide. And when you're doing portal height there, okay, this picture here, this is how our cartoons show these thingies where, so what's happening is the patient has the blood pressure inside their liver is super high, right? The liver is scarred, it's squeezing, it's like a sponge, you squeeze it, right? So the pressure in the liver gets higher than it's supposed to be, pushes blood backwards, opposite of the way God intended. It goes down the back into the splenic vein, you get these huge, your spleen gets huge, you can get varices, you get ascites and so on. And in the cartoons, we always see one varix to pop off, right? Blood goes back down. We always see it coming off of the portal vein or the splenic vein or the coronary vein. And then it goes up through the stomach and then it drops into the adrenal vein, into the renal vein, into the IVC as a way to get back to the heart, right? The truth of the matter is it's not one vessel, okay? There's a million. And now go back one slide. This is why this is hard. This is, okay, there you go. This is more accurate. You have all these veins here, the short gastric veins that come off near the hilum of the spleen. You have posterior gastric veins that come off the splenic vein, and there's a zillion of them. a lot of inflow to these varices, okay? There's one outflow, that is the shunt into the adrenal vein or the renal vein on the systemic side, right? And so that's why we try to treat these on the systemic side. That's one reason among others, but as we go into the femoral vein, cava, renal vein on the left, and then the adrenal vein, get in the varix, and we want to occlude the outflow because there's one outflow. There's a million inflows and one outflow. And so if you can occlude the outflow, then you will shut down all of the inflow. They'll go away. They have, and then you sclerose them, and then there's nowhere for them to go. So that's why, to me, and if you've ever tried to do an antegrade variceal embolization where you stick the liver into the portal vein and then you go into the portal vein and you do an injection, you will see one dominant vessel that goes up to the gastric varices and several small ones. You embolize the one big one, you feel like a hero and everybody's high-fiving, and then you do another injection, and what do you see? You will see the next one that's taken over and a new dominant vessel goes up, right? It's just like whenever you adjust your air conditioner vents in your apartment or your house, right? If you turn the air conditioner flow off into your bedroom, it shunts the air into your living room. Turn that one off, it shunts it in the dining room, right? The air is still there. So that's what happens, is you get a new dominant vein that pops up. So if you go antegrade, you have to embolize every single one of these, or it's a zero. And that's why, to me, it's like, it makes sense why the cyanoacrylate injection, they're going to inject a few vessels here, yonder, and now, but they're not taking out the outflow of the portal systemic shunt. So it will just recruit from somewhere else, and it will flow on the systemic side. So that's just my simple thinking in a nutshell about why. And if you've ever tried to do a BATO, or if you're naive and you did one earlier in your career and you felt like a hero, and then you got a follow-up CT, you see the varices are all still there, and then you feel real stupid. And so that's why that is. So that's one reason to do BRTO. Also, it's lower risk because it's on the systemic side instead of sticking someone in the liver who's got a sick liver who probably has ascites. So it's a higher bleeding risk, right? When you go that way. So, okay, now we can answer questions. Sorry. I just want to make sure everybody kind of gets that. This is super hard to wrap your brain around. In fact, one of my fellows always says he wants to do a study where you just ask residents, even in radiology, how would I get a catheter in the portal vein? It would be an interesting study just to see what would people say. I think most people would say the femoral or the jugular approach. They don't, like, those systems don't talk to each other, right? You have to stick a catheter, and the answer is the spleen or the liver, right? And so those things don't normally talk to one another, and so it's important to, it's hard to tie that stuff together. So anyway, all right, let's go do some questions. Unless anybody has questions about this paper or whatever, we'll go to the Q&A.
Yeah, thank you so much. So we got another question here. It's sort of along this topic.
You said how do we do it at UNC? Was that the first question? I didn't answer. That was the first one.
Yeah.
Oh yeah, sure. So generally here we use it coils or plugs or both with sclerosant. So the idea of leaving an occlusion balloon up in somebody's adrenal vein like overnight, that's just like a logistical nightmare, like for your hospital, like you're gonna do what, and you're gonna have to send them to the unit. The nurses are, what, while you're waiting. And the reason you do that is because I'm telling you, it's like a fire hydrant coming at you. So what you do is you get into the varix, you put up an occlusion balloon, and then you inject sclerosant of some sort, a detergent. We use typically STS or sotradecol. That's combined with air, sotradecol, and lapiodol, which you showed a little picture of, which is a thiodized poppy seed oil. You mix those things together in a syringe, and they make this foam. It's got a huge surface area, and so you put the balloon up right there off of the renal vein, like you showed there, and then you inject after it's occluded. Then you can, through the occlusion balloon or the Fogarty balloon, you inject the sclerosant mixture, and you just push it up into the varices. Right. And it can't flow. It wants to flow. It wants to fly into the renal vein, into the cava, into the heart and lungs, right? And give them loads of pulmonary emboli. And so you have to leave the balloon up for a long time to let that detergent set up and occlude the vessels, like you see in these beautiful pictures here. And so historically, papers describe leaving balloons up for hours, right? for a long time. Now, we did a study here a long time ago at UNC when I was a medical student, I think, on short dwell times and beer. That became popular because in the United States, it's kind of impractical to leave these balloons up forever. And so that's when smart people said, well, why don't we put a plug up there, something we can leave in the patient, right? Like an Amplatzer plug, or that's what the PARTO there. So you put a plug in there, you inject your sclerostin, and you leave the plug. It just stays there forever. Or coils or both or whatever. So at UNC, we tend to, if I can get an Amplatzer plug up there, I will. Or we use coils sometimes. We did one of these today in the shop. I think I used a coil. Yeah. And then we use, and sometimes so you'll coil off those little inferior phrenic veins that come off of the adrenal vein because you don't want to put the sclerostin into the systemic blood supply, right? It will go to the lungs. Also, you'll get a pretty bad pleural effusion if you put that into the inferior phrenic vein. It'll piss off the diaphragm and you'll get pleural effusions. In fact, I think some earlier papers by Dr. Sabri, if I remember, he's written a ton on BRTO. He said you should get a chest radiograph the day after a BRTO to look for the presence of a pleural effusion.
Awesome, thank you so much. And then another question we have here is, how important is it to nail down the specific gastrovaricose class when it comes to treatment decisions? So I think they're talking about
Hang on, to nail down the what now? Let me say.
Oh, the gastric varicose class, kind of like.
Yeah, no, that's so that's the hepatologists do that. It doesn't. So you guys know when you have esophageal varices, you treat those with rubber bands, right? You put rubber bands around them. You, as in a hepatologist or a gastroenterologist, not you as in an interventional radiologist, but somebody puts a scope down there and they put a rubber band around them and then they thrombose. You can't do that in like those GOV2s. You can't do it because the scope, you have to put a scope, it's coming from above, right? And then it goes in the stomach. It has to retroflex 180 degrees. It's impossible. Like they don't make a fiber optic scope that can actually make that move and then rubber band things. And so from just technically, it's kind of not possible to do it with an endoscope. It doesn't particularly matter to me, to tell you the truth. If somebody comes in, they're hemorrhaging from gastric varices, if they have a portosystemic shunt that we can access, then we go for it. Yeah, almost always. The caveat might be if it's in the middle of the night, then I might actually choose to TIPS the patient and then do an antegrade embolization if their MELD score can tolerate it. If they could tolerate a TIPS, to me, PRTO can be technically challenging and can take a lot of time, and maybe in other skilled operators' hands, it's not so challenging. But to me, I can do a TIPS a lot faster than a BRTO most of the time. Sometimes I'll start. I can remember a case I had about a year ago where the hepatologist like, I just don't think this guy can tolerate a TIPS. Please don't do it. And I tried for a long time to get into that. It can be very hard to negotiate a sheath into that varix. And I tried and I called the hepatologist. This is in the middle of the night, and I said, man, I've been burning a lot of calories here. This guy's bleeding to death. And he said, okay, yeah, just TIPS him. And so that's what we did. And then embolized him. Actually, the guy, he did okay, mercifully, but yeah. But no, the particular type of, it doesn't bother me. What if it's GOV, whatever, that's, yeah. Maybe Dr. Vatican-Cherry has a different opinion.
Awesome. Thank you.
Mm-hmm.
And then we have another question here that's a little bit off topic, but related. Someone asked, what got you interested in interventional radiology?
Wow. So I had a friend who was I'm a mathematician. Okay, that's my background. That's what I did. I used to work for the Department of Defense for the Air Force, and I had no background in medicine, and then decided to go to medical school. And after I did a PhD and stuff. And anyway, when I was a postdoc, I did a postdoc here in statistical genetics at the University of North Carolina, and met a person who was a diagnostic radiologist, and she just kind of became a friend of my wife and I. And she said, I think you should meet these interventional folk. This is back in the day now when this is in 2009. So like back then, IR was not popular as it is today. Right. I mean, back in those days, probably almost half of fellowships didn't get filled. Now smash cut to IR is the most competitive thing to match into. And so so there wasn't med students hanging out in the shop. That wasn't a thing. And so when I started, she said, hey, maybe you should go meet these guys. I think you'd like them. And I like diagnostic imaging. And so I just went and hung out and just met a group of I'll never forget, the first thing I ever saw was a bronchial artery embolization, which you guys may not know, that's not super common. To see an angiogram, somebody with hemoptysis coughing up blood. And that was the first thing I ever saw. And it was the coolest thing ever. And I just started hanging around more and trying to learn more about it. And I like that it's all over the body, and that you can do a BRTO or a TIPS, and then you can put a central line in, then you can do a biopsy, and then you can go ablate a renal cell cancer, and then you can go to lunch, and then you come back and do a G2, just all over the place. And I get super bored pretty fast, I guess. So, if I was just doing the same thing over and over and over and over and over again, I probably wouldn't care for that. So I like that it's dynamic, and that we're kind of, I like being a consultant. You guys will figure that out pretty quick, whether you like being a consultant or you like seeking consultants' opinions. And so I like being a consultant. That's fun. I also trained at a place where we had titans in the field, Matt Morrow, who you guys probably, I don't know, you probably don't know who he is, but he's a household name in the radiology world. This guy wrote one of the early textbooks in IR. So we had amazing interventionalists here. So that was incredible to work with folks that, whose names wouldn't really mean anything to you guys, but anyway, who are just like total all-stars and like making the Pro Bowl every single year. These guys, Charles Burke, Ari Isaacson, Bob Dixon, Heon Yu, who was a wizard with a catheter. So anyway, it was easy to be influenced when you're in the presence of greatness,
Yeah, absolutely. Thank you for sharing. I think you have answered all of the questions in the Q&A all in one. If there are other lasting comments or questions, feel free to put it in that QR code or in the chat. Otherwise, Deshaun, do you have anything else?
No, just wanted to say thank you so much, Dr. Commander, for explaining everything. Those explanations were in like amazing terms. So thank you.
So as you guys go, thanks for that, and thanks again for having me, and thanks to Dr. Vadakancherry, who he probably doesn't know me, but I know who he is, and anybody who's in medical school or ever wanted to do VIR knows who he is, and is very you should know, and you should be grateful that he's out there advocating for students who think they want to do this without folks like him, who's just doing this all day, every day, and at every single meeting, and never seems to run out of energy for this. I did one of the IR at the SIR. They have a great program for medical students and residents, and I participated in that, and that was great for me. And it's a good field. As you go through medical school, let me just give you one thing. Just talk to, if all else fails, talk to the patient. That's number one. Okay. They'll usually tell you what's wrong. Number two, just talk to them like you're talking to your neighbor over the fence. Okay. They'll like you a lot more. And so will everybody, quite frankly. Don't get in your head with all these fancy pants doctor words and stuff. Patients don't really care for that too much. And if you just talk to them like normal people, they're usually at the worst part of their life. If somebody has to come meet an interventional radiologist, they got bad news. And so just talk to them like normal human beings. And I think that's super important. I would get it's fun. Anyway, I probably don't fit the model for what my medical school would teach medical students how to talk to patients nowadays, but I just talk to them like, like they're my neighbor. And so that's important, because it's no big deal to us, putting in ports or central lines or doing these things that we do 15 times a day, but for that person it's a super duper big deal. And I'm not getting preachy or high horsey here, just remember that as you guys go through, and you're all big shots, going to be super prestigious interventional radiologists and stuff. Just remember the folks out there.
And yeah, that's very true. We can't ever forget our roots from where we come from. And
Yeah.
when we were pre-meds, thinking about
Yeah.
lives.
Absolutely.
Awesome. Well, thank you all for coming. Thank you so much, Dr. Commander, for your insight and wisdom, and Dr. V for being here also. And it looks like they're adding some stuff in the chat.
Yep. Thank you guys so much. And thank you for the great advice, Dr. Commander.
Thank y'all. Yeah, my friends call me Clayton. Y'all if y'all need anything, reach out to me, and good luck as you go through all of your training and matching. And that's super exciting. Congrats to the two that you just mentioned a little while ago. That's really fantastic. Thanks for letting me be a part. Thanks very much.
Of course. And then finally, just all the members that are here today, thank you so much. If you do not already get our emails every month, please DM us on Twitter or Instagram, or email us so we can add you to the list. But other than that, have a good night, everybody.
Thank you.
Good night, everyone.
Good night. Thank you.